You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Millions of women worldwide swear by Ovasitol, the #1 inositol supplement by Theralogics for balancing hormone levels. Theralogics also offers a wider range of evidence-based fertility supplements for men and women, trusted by the top fertility clinics across the country. All Theralogics products are independently tested and certified for content accuracy, purity, and freedom from contaminants. Theralogics, supplements from science.
Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I am joined by my exciting and entertaining co-host, Dr. Susan Hudson from Texas Fertility Center, and Dr. Carrie Bedient from the Fertility Center of Las Vegas. How are you guys doing?
Hey,
Doing good.
What's going on
here?
so earlier this weekend, I got a gift for my birthday that I was finally able to go schedule for, and it is to help me with my fashion sense, which it does kind of look like an angry raccoon has dressed me in the dark some days. I have gotten much better about it because I know the colors that I look good in, and so I just get the same things again and again because it's hard to go wrong with it. But it was like getting colors done, so actually analyze some of the more subtle things about colors that look good. And so the woman who did it had all of these like scarves in different colors, all organized by spring, fall, autumn, summer, and went through some of the really subtle differences, which was cool.
So does she categorize you? Because a long time ago, you used to either be a spring or a summer or a fall. Do they still do? Is that sort of the same kind of thing?
Yeah.
What look good? What
season are
was
you?
your thing? I think Abby's a spring.
A spring. My bright neon bubblegum pink shirt today.
So I'm a winter.
And so winter is like...
Winter is the like clear, vivid, high contrast type colors, like the icy colors. There's very little blended colors. Like it's a lot of really straight, bold
primary colors, red.
Not primary colors, but just really rich colors.
To do with the fact that you have such dark hair and such fair skin, it's very like...
Yeah.
And Susan
like
probably
fall?
is a fall. Yeah. Your hair is the color of autumn leaves. So
I have to say I love shopping this time of year.
I love shopping any time of year. Well, that sounds cool, Carrie. I'm excited for you. Can you send us some pictures? I think those would be good Instagram pictures of you, like with different scarves around your neck and around your face.
One where I've got different scarves of all of the winter colors right next to me. And then she put it right next to one, which was a summer color that was cream as opposed to a crisp white. And I never would have noticed those differences before. But when you look at the pictures side by side, you're like, you kind of look sallow in the one, and I look much brighter and better, more glow. I don't know what the words are, but looks better in the one versus the other. And I never would have thought about that. To me, it's white.
Well, and anytime you're a painter, you have colors that are cool colors and warm colors. And for example, when I got married, I don't look good in white. And so my wedding dress was kind of a champagne. It was kind of and it looked so much different than like stark white. Even in a color like that, there's very subtle differences. And like white paint on your wall too, there's subtle differences if it's a warm white or a cool white or whatever. So that sounds fun.
When I think about my wedding dress, it was a super crisp, clear white. When I looked at the cream ones, it looked like I'd fallen into a dirty puddle or something. Didn't know how to do laundry, washed something with a black or brown new piece of clothing that just kind of got everything a little off. Yeah. So.
Well, very cool. So today we are going to talk a little bit about IVF, and we're going to answer listener questions about IVF. So Susan, I'm guessing you have some questions for us?
I have a lot of questions. All right, here's our first one. Hello, I'm considering doing an egg retrieval abroad for many reasons. Have you worked with patients who might do diagnostics here and then begin stems overseas? Are there some things to look out for when choosing an overseas clinic?
Carrie, you might be in the best position because you work with a lot more overseas practices than I do, for sure.
Yeah. There's a couple. One is related to what you intend to do with those eggs or embryos later. There are some people who need to work with surrogates or egg donors or things like that. And for the US, as heinous as all of the regulatory stuff is that we have to go through, it's all there for a reason. And so it's very clear where everything came from, who they were. The information is really clearly disclosed, and that is all very helpful. But even when you're doing it just on your own body with your own intent to carry the pregnancy later with your own partner, where there's not any of that third party donor surrogate stuff involved, protocols that occur in other countries are not necessarily the same as what we do here. If you look at particularly some of the European countries, they don't push in the same way that we do, and their success rates reflect that. And it's not to say that they're bad at what they do at all. It's just that there is a different approach to it. And in part, it's because of the healthcare systems they work within, and that has an impact.
And by push, you mean they don't push somebody to stimulate as many eggs. Is that what you're talking about?
They're not as aggressive. I can say in Texas, what we see most often are people going down to Mexico to do egg retrievals and that type of thing, and realize that you may not have the same quality lab, and the lab matters. It's not to say that you can't get great care somewhere else, but make sure you're really comparing apples to apples as much as you can, and know the services that you're going to get. Are you going to have the option of ICSI if you need it? Are you going to have the option of PGTA or chromosome testing on your embryos if you need it? Do they have good blast numbers, or are they doing day 3 embryo transfers on 28-year-olds because their lab is not great, and that's the only way they can compensate is to get it back inside of you as fast as possible? These are all things to think about. And then, as Carrie was kind of alluding to, also know that if you have any intention of those embryos coming back into the United States, getting embryos through customs is not an easy feat. If you know, it is possible, but it's not something that is easy. And there's a moderate chance that your embryos could end up stuck in customs longer than the liquid nitrogen that they're stored in is guaranteed for.
Had embryos that were supposed to be sent to me from another country, and this clinic sent out 2 sets at the same time. I got embryos that were supposed to go to the country of Georgia, and the embryos that I was supposed to get went to Georgia instead. And so, I mean, both labs were great. They topped off the liquid nitrogen and they ended up in the right place. But oh my God, everybody had chest pain with that one until we had what we needed, because you're never quite sure what are they going to go through at customs? How long are they going to be stuck there? Are they going to be exposed to x-rays or other things? What are the rules? There are some countries where you can't even freeze embryos. That's not allowed. And so knowing the rules of wherever you're going, knowing what their research is, when you look at some of the research coming out of European, otherwise very scientifically developed countries, and you read those papers, oh, why are their success rates so bad? And they're saying, oh, these are amazing. If our lab put that out, we would be overhauling the lab to figure out what was going wrong.
There are limited countries where you can only inseminate a certain number of eggs, but there's a lot, if you're considering Europe, there's a lot of Europe that PGTA is not legal, whether you believe in PGTA or not. And I think all 3 of us do. It makes a big difference in really diving into why are you doing your IVF. If you're doing IVF for recurrent pregnancy loss or unexplained infertility, those are times that I think that PGTA are especially warranted, or if you're over 35, especially if you're in your 40s.
Well, the other thing I think about when you travel, and it's true when you travel in the United States, but even more so to different countries, is things go pretty well 98% of the time, but there's a few percentage of the time where things don't go perfectly. Maybe you get hyperstimulated, or maybe you get pregnant and the hormone levels are not going up well and they're worried about a tubal pregnancy. So sometimes patients are in a bind, because then they come back to this country and everybody's, well, you don't know what they did. And so those are other things to think about too, is there's splintered care unless you're going to stay put in that country for a while, and make sure they manage any side effects or problems you may have from procedures that are done there.
The impact of your social situation. Are you married? Are you not? Single, same-sex couples, any variation, male, female, heterosexual, starts to run into a lot more problems internationally. Again, not guaranteed. There are places that are totally fine with it, but there is there is a big reason why the US attracts so many international patients is because it's stuff they can't get in their home countries.
Let's get to our next one.
Good question.
It was a good question. Okay. Hi, my husband and I found out they were carriers for the same fatal genetic condition. We are both 26 and have no known fertility issues. We are pursuing IVF to ensure we don't pass on this disease to our children. Will our IVF experience differ than somebody who has a fertility diagnosis? I know a lot of information is about infertility, but I'm trying to understand the process for our situation.
What do you think, Carrie?
So there's a couple aspects of this. One is that there's such a thing as unexplained infertility, where all of your testing is stone cold normal, and you don't know until you're actually trying to get pregnant. We don't really have a whole lot of information as to how this couple found out that they both carry this fatal disorder. I very much hope for their sake that they did preventative testing and found it before they found out the really, really hard way. And so there's always that aspect. But one of the biggest things that you will encounter is that even though you're young and hopefully all of your testing is stone cold normal, is a larger percentage of your embryos are going to be unusable, not just because of the normal aneuploid, incorrect number of chromosomes that develop, even a young person, and that's normal, but also because you're going to lose a solid 25% of your embryos because these two genes are going to combine, and those are going to be the unusable embryos, which it's good. You want to know that. That's the whole reason you're doing it. But it does mean that you very well may have a far lower number of embryos at the end of one cycle than someone who's got, fertility treatment because they're going through PCOS or have a low sperm count or some of these other reasons. And so you may not be able to as easily compare to one of your counterparts who's the same age and going through IVF because of the additional testing that you're doing. And that's normal. That's why you're doing it. But it makes those comparisons really a bad idea.
I think there's two differences. One, if you're coming into this without a diagnosis of infertility, you are coming into it more, maybe not in as negative a psychological point as a lot of our patients do. So you may be actually starting off on a good foot and have a little bit more resilience than what we sometimes see. It is stressful. It's stressful no matter why you're doing IVF. It is definitely a stressful process, but know that it is stressful. And so have your community, however you like to release stress, make sure you have those things going on. And you'll also need a little bit more lead time. What you're doing is a process called PGTM. Okay, so we're looking for a single gene that's causing a disease. Whenever this happens, we have to have a probe, which is essentially kind of a device that will specifically look for your and your partner's mutation. To develop this probe, we often need samples of either blood or saliva from other family members. Sometimes people are taken a little aback by that, but that's part of the process. And it usually adds about 4 to 8 weeks onto the process. And so that's something to mentally prepare yourself, because if maybe you got this testing done preemptively through something outside of a fertility clinic and you're like, okay, I have my new patient appointment next week. That doesn't mean we're getting started next week. You're still going to need to go through a basic fertility evaluation, and you're going to have this probe created. So it does take a little time. So that's just something to be forewarned about.
To piggyback on what Carrie said about sort of the funnel effect, and this, I use her terminology because she started out with this, anytime somebody goes through IVF, no matter where you're coming from in terms of your diagnosis, you start out with a certain number of eggs, and at every step, that egg number drops down. And quite frankly, the disadvantage that you have if you're doing genetic testing for a specific condition is, first, your embryos have to go through the funnel effect to figure out which ones are normal, which ones are abnormal. And it's about a 50-50 proposition if you're 26 years old. I think you'll do well, probably because you are 26 years old. So I think you'll do as well as anybody. But still, I think you'll be surprised by how much that embryo number drops. And then ultimately, once we do testing to make sure that the embryo is either a normal boy embryo or a normal girl embryo, then your embryos, like Carrie was saying, go through one more filter, and there's one more layer they have to go through. Keep this in mind. It's not unusual for patients to have to go through more than one IVF cycle sometimes to find a healthy embryo. And hopefully that won't happen to you, but I would just keep that in the back of your mind that that's a possibility.
All right. Our next one. First of all, thank you for your podcast. Thank you for listening. I've done 2 egg retrievals and awaiting to do an FET. With ultrasounds, the tech has always had trouble finding my right ovary. First ever doctor told me point blank, it's because you're too fat. My BMI is about 38. We changed clinics, and since then, I've been assured that they just sit high, and that's normal for ovaries to float around. My first round of stems, they got full of follicles and dropped, making them easier to see. However, they couldn't see my right ovary during egg retrieval and actually punctured my uterus trying to get eggs. They retrieved 7 total and no embryos. Second round, they never could see it the day of egg retrieval, and it was very visible, and they got 13 eggs and 5 embryos. I never hear about this and wanted to know your thoughts. So the wandering ovary.
Ovaries running high definitely happens. And sometimes it can be for a whole bunch of reasons. Sometimes it's just how you're made. Sometimes you've got a particular ligament that's a little bit shorter that holds it up higher, so it doesn't have the capacity to drop to the same extent. Sometimes it's a product of scar tissue. If you've had inflammatory processes go on in the abdomen, whether that is infections, whether that's a surgery, particularly if it was a complicated surgery of any type, anything with a lot of bleeding, that myomectomies, all of those things are a little bit more prone to scar tissue.
Sections.
Bowel resections, especially.
Yeah.
All of those things can pull an ovary up and out of the way. Now, when you are asleep in a retrieval, we do have the capacity to push harder. And the things that you cannot do in an ultrasound while somebody is awake, you can do while they're asleep, because you can push on their belly and try and get it to come down. But sometimes those ovaries are up and out of the way. And going through the uterus to get to them is not necessarily a problem, in the sense of the uterus is a very forgiving organ. I mean, it can take growing a watermelon seed to a full-size watermelon and evicting it multiple times over the course of your life and be perfectly happy with that. Whereas a lot of other organs, if you so much look at them cross-eyed, they get pissed and they run away. So the uterus can tolerate it, but it does make the procedure more difficult for us. The uterus is a very different organ to go through than just the vaginal sidewall.
And it also is more risky because there's a lot of blood vessels close around the uterus that sometimes we can see well and sometimes we can't. So it's a little unnerving and a little tricky to get around vessels in the uterus to get to a real high ovary sometimes.
It's a very true thing that ovaries do not stay in the same position. They can go up and down, and sometimes we can see things better at egg retrieval. Like Carrie mentioned, we can apply more pressure because you're asleep, but sometimes ovaries also just aren't accessible. And unfortunately, that's something that we do deal with.
Yeah, and just like everything, safety is our primary concern. Nobody wants to go in and not get both ovaries. We're disappointed, patients disappointed, but the number one priority is your health. And we certainly want to get as many eggs as we can, but we don't want to injure organs in the process. I will say in our office, sometimes we'll do bowel preps on patients, because really the things that are down in your lower abdomen are your ovaries, your uterus, and your bowel. And so sometimes if we can get the bowel decompressed and get it out of the way, sometimes we have a better shot at getting the ovary. So if someone hasn't tried that on you and you're going to do another egg retrieval, I would mention that and think about doing a bowel prep. And sometimes we'll even have patients do a clear liquid diet the day before, just to really decompress the bowel as much as we can, just to give us more room to get to that ovary.
One of the ways that the weight plays in specifically is that it depends on where you carry your weight. Some women carry their weight in their middle and in their chest. When they're breathing during a retrieval, their chest wall is going up and down, and that has the downstream effect of pulling the ovary up and down every time they take a deep breath in, and they can't control it in the same way because, of course, they're asleep, so that we can safely do the procedure. And so that means that we are chasing an ovary every time you take a deep breath in and out, and you can't necessarily aspirate all the fluid to get it out, to get the egg that fast. And so it's very scary to have this long needle and have the ovary move up and out of it. So you suddenly have this uncapped needle in the middle of the abdomen. And that does become more of a challenge when someone is carrying extra weight, in part because of where they carry their weight, and also in part because of how long the needles are. We deal with really long needles. That's typically not the issue. It's just there is a length to what you can safely control, and that plays a part as well.
And always remember that when we're trying to help you during this journey, your safety is our number one priority. So if it comes between potentially causing harm to you and getting an egg, you win every time.
Yes.
All right. Hello. I'm a 40-year-old woman turning 41. AFC 14, AMH around 3 when we checked it last year. Have had one chemical pregnancy, tried through 3 IUIs for insurance purposes. My husband and I have done 2 egg retrievals, but have had issues with maturity or not fertilizing and only have 1 euploid embryo. We're about to go through another retrieval and have budget to do a 4th and final round. We were hoping to do back-to-back retrievals to get it in before the end of the year lab closures, which would put us in January or later, which I worry about with my age. Any downsides to doing back-to-back retrievals? What about duostem for someone my age? I have read some things online that it's possible to get good results with this. Thanks.
So our practice will do some duostems. I'm not a huge fan of the duostem. I just talked to somebody the other day about this. Essentially, that's where you go through a typical IVF cycle that takes 12 to 14 days. And then really right as your hormone levels are coming down and you start a period, or even before that, sometimes we'll even start you in the cycle. The problem with the duostem, in my opinion, is you end up having to use so much more medicine in that second cycle, and it takes a lot of days. It takes much longer to get somebody stimulated. And sometimes we don't get as many eggs with the duostem. So it can be done, but I'm not a huge fan of it. I think the difference between doing a cycle, waiting a month in between, and then maybe starting another cycle in January, if it were me, I would do that as opposed to do a duostem, because I don't think we get nearly as many eggs with the second stimulation.
I don't think anybody's shown that they are definitively better or worse. I think that there's enough variation that you do have leeway, but especially when you've got a ton of eggs, duostems were made for people who only have a couple of eggs, because that way you get the first handful of eggs and then there's just not as much that has to recover before you do the second one. For somebody who's got a ton of eggs, I don't really like the idea of going in immediately, because you're going into an ovary that hasn't fully healed yet. And so I think some of this is based on individual circumstances. And with an egg count of 14 and an AFC of an AMH of 3, I don't know that you're really very well served by a duostem, other than just getting it done with so that you can mentally move on to the next stage, whatever that may be. I'm inclined to say, like, just wait a little bit longer, take the month, have a breather, and then let your body recover and go into the next stim if you need it.
I agree. Our next one, I had an AMH of 0.7 with vitamin D deficiency. After supplementing, my AMH went up to 1. AFC all over the place, 8, 10, 17, 10, ended up being 5 at baseline for my first retrieval, got 2 eggs, both mature, both blasts, both genetically normal with PGT. Husband sperm, low motility, 31%, total motile 11 million, 3% morphology, both of them are 34. Question is, halfway through the second cycle, 14 follicles, wondering if we should plan to do PGT testing if we have any blasts to test. Also, is low ovarian reserve a good diagnosis for me, given me my up and down AFC? Thanks so much. Love the podcast. Thank you for listening. Yay.
What do you think, Abby?
I would say congratulations that you did fabulous for an AMH with a 0.7 to have 2 eggs and have 2 blasts and both be normal. That's incredible. That's amazing. That's wonderful. So I think you don't make many eggs, but you do a really good job of it. I think that your diagnosis probably is decreased ovarian reserve, but the question was, should she go back into another cycle? Was that the question?
No, should she do PGT testing if she has any more blasts to test, since she has 2 chromosomally normal embryos?
I'm a big fan of PGT testing because it helps really narrow down if it's good embryo. Because if you go through another cycle and you have 2 blasts again, they may be 2 abnormal blasts and you don't know that. It depends a little bit on money, obviously, because it's expensive. If you have insurance coverage for it, I would absolutely do it. If you don't, I've got those 2 normals, so you could go ahead and potentially have 2 babies and maybe think about testing those later if you wanted to, or gamble based on the results that you got from this cycle.
You might even think about transferring untested embryos before transferring tested embryos later on. I'm guessing you're wanting to have more than 1 child. Otherwise, you would have already gone forward with an embryo transfer. So if I'm hedging my bets, I would rather transfer my untested embryos, understanding 50-50 chance they were abnormal. And then if I'm pregnant with one of those, great. If not, then move on to your chromosomally tested ones. Another way to think about it. I also would encourage you to consider PGT testing them. But if you chose not to do, I would almost think about transferring those untested embryos first.
Yeah, particularly if you're not going to go through one more time. If you transferred the untested, and if worst case scenario, or bad scenario, you got pregnant, had a miscarriage, it's going to take you out of the loop for a few months before you would be able to get back into cycle again too. So that's something else to consider.
And a lot of times the financial works out such that doing PGT is cost of one embryo transfer. And so if you identify that, hey, there's a couple of abnormals in here, you probably cut even on the financial part of it, plus saved yourself some heartache as well. Because if you can avoid a round of progesterone shots or a negative pregnancy test or a miscarriage, so much the better.
Exactly. Our next one is, I went in for my suppression check before starting stems and they found a cyst on my ovary that was producing hormones. My RAI said they could do a trigger shot that day and still begin stems in 2 days with the gonal F dose being higher. Is this a common approach you would take? Could this ruin my outcomes for egg retrieval? He did also give me the option of cancel the cycle and wait for the cyst to resolve.
What do you think, Carrie?
Some of this depends on how old she is, because someone who's 30 years old, you're maybe a little bit more inclined to say, just wait a month or two and let's do this when you're 30 and a half years old. For someone who's 40, 41 years old, there's a little less tolerance for waiting. That said, some of this depends on, is that cyst there normally? Do you normally have other cysts? Are you someone where your FSH is high enough such that you routinely make cysts going into a cycle where it doesn't matter if we wait and do it another month, this is likely to happen again with another cyst. And so you might as well just bite the bullet and go ahead and do it now, versus this is a more random thing, or this is the very first time you're doing it. And so it makes more sense to wait, because on the one hand, you don't want to charge into a cycle that's not ideal. But on the other hand, you don't want to waste time and effort and money and emotional reserves waiting for something that you're going to have to trigger or drain in order to get into cycle. Some of this depends on circumstances that we don't necessarily know about what your case is. Given the option, especially the first time, my preference tends to be, let's wait, let's put you on a longer suppression, let's trigger it, let's go into a luteal start. That happens to be my MO, because it's an equally as easy way to optimize what's going on. But there are some patients where they just have cysts all the frickin' time, and you have to work around that. And we know how to do that too.
Yeah, I think there's a lot more to the story that we may not have knowledge of. I tend to, if I'm going to trigger somebody like this, I usually go into like an estrogen priming. I don't go straight into a stimulation, but that's just the way I typically do things. This is definitely one art of medicine where there's a lot of ways to handle this.
Yeah, and I would say it's probably not optimal to trigger. I mean, wouldn't typically do that. I think for cancer patients, sometimes we do that if we're trying to get into a cycle really quickly. But like Carrie said, if this is your first cycle, I probably wouldn't trigger you, and it would be more optimal if you would wait until your next cycle to get started.
Our next question is, hi docs, thank you for your amazing podcast. Again, thank you for listening. My husband and I are both 36 and dealing with secondary infertility. We have DOR and male factor, AMH 0.6, AFC 10, FSH 10. Only sperm issue is 2% morphology. Just did 2 back-to-back antagonist rounds of IVF, letrozole 300 follow-stem, 20 units low-dose HCG, dual trigger. My first round was 8 eggs retrieved, 6 mature, 5 fertilized, 4 blasts. That's awesome. Second round, only difference was that it was back-to-back in 8 days versus 10 days of stem and added omnitrope. I had 5 eggs retrieved, but only 1 mature. What do you think the maturity issue was from? Does back-to-back ever cause issues, or were the stems too short? My retrieval was also an hour earlier at 34.5 hours versus 35.5 hours. There's a lot of information in that one.
So this was duo stem then, basically, right?
Yeah, it looks like a duo stem.
And again, it's unique to each individual, but as we were talking about earlier, duo stems sometimes don't go quite as well as just kind of waiting. Who knows if that's what it was? I mean, because certainly we've had patients that have done everything absolutely perfectly, timing wise, and still end up with some immature eggs. Did she have HMG added at all to her stem?
Low dose HCG.
She did. Okay. Yeah. So if I were planning your stem again, probably wouldn't do a duo stem, and I probably would give you HMG, which is a little bit more powerful than giving you HCG. We do that often. We do HCG every other day or daily. But I feel like if I see patients that have maturity issues, I would add an HMG in addition to what you've been doing.
So I'd be a little concerned that you did dual trigger back to back on a duo stem, just because with your initial trigger, your internal hormones probably responded more aggressively than they did having another Lupron trigger 2 weeks later.
Yeah.
And so that's a very, very short interval. And most dual triggers, you use a little bit lower dose of your HCG trigger. And so either if you have to do dual stims for whatever reason, doing a full HCG trigger, I think would be reasonable, or spreading it out more. I do think, as much as we just talked about, that dual stims probably don't cause much harm, it may not have been an ideal circumstance for you.
If you had 34 versus 35 hours with a longer stim, I don't think that's going to make a difference, but it may be something that in this particular setting leaned a little bit more one way or the other. I mean, doing retrievals 34 to 38 hours is normal within the standard.
Well, and the huge positive is you proved in that first cycle, you did great. You had 8 eggs and 4 made it to blastocyst. That's great. So
Yeah,
it can be done. And sometimes it's just you just have a one-off. It just doesn't go well. And hopefully your doctor will be able to build on what you did in the first cycle medicine-wise and hopefully get a better result if you do it again.
Yeah. Want to do one more? Hi, docs. First off, thank you for all the work you do to make the science of fertility so accessible, but at the same time, not holding back on the detail and nuance. Thank you so much for listening. You're an invaluable resource. I have undergone 2 egg retrievals in freeze-all embryo cycles. My question is, my AFC both times was around 14, but we were only able to retrieve 7 eggs each time. We did not change the protocol, Follistim and Minipure with estrogen priming from the first to the second cycle, except starting a slightly higher dose the second time. My question is it normal for the actual number of eggs to retrieve to be so much lower than the AFC at baseline? Would it make sense to try to change the protocol if we were doing a 3rd cycle? Thank you.
So anything can happen. You never know what's going to happen. You never know which eggs are going to stimulate, which aren't. And AFC is a place that we start at, but when we start to give you the FSH medicine, it's hard to truly know what happens in your ovaries, but I suspect that some are better equipped to respond to the FSH, and so the FSH, as they bind to some of the eggs, some of them grow faster, and the rich get rich, and the poor get poorer, and so you have a group that come and grow quickly, but a group that just don't respond at all, and that's unique to the patient, based on your age, and just based on the quality of your eggs. So always disappointing when you see a good AFC count, but you don't really have eggs that stimulate and grow in the way that you would expect. So the answer is, yeah, it does happen. And as far as changing the protocol, I think they did go up on your dose in the second time.
Mm-hmm.
Other things to consider, it might be a microdose Lupron flare. I didn't see what your AMH was, but if your AMH is a little bit lower, that sometimes can also work to your benefit. It gives you a little bit more boost because your own FSH is released in addition to the FSH that they give you. So that might be something to consider for another stem.
I have questions. I want to know what your trigger was. I want to know what they found at retrieval, because sometimes you can go into those follicles and find out, oh, we're getting endometrioma fluid. And that plays a part in it.
Meaning there's no egg there.
What was that?
Meaning there's no egg there.
Meaning there's no egg there and there never was going to be?
But there wasn't, yeah.
I'd be interested in knowing what your FSH level was to figure out, do you need a higher dose, or are you at a plenty high dose and it's just your body that's not responding? Because that has an impact as well. There are other protocols you can try, like the microdose flare that Abby was mentioning, but I have questions. I want to know what else is going on to figure out what makes the sense versus to tweak versus not to tweak.
Yeah. When I'm working with my patients, I don't usually emphasize an antral follicle count at the beginning of the stimulation.
I don't usually either.
I think that, when you're getting triggered, that number and how big your follicles are is way more predictive of how many eggs we're potentially going to get. Sitting there being like, oh, I have an antral follicle count of 14 and I think I'm going to get 14 eggs. I honestly would never promise that to somebody. And the other thing to remember also is this might be a component of your fertility challenge. So we always say that IVF is not only therapeutic in that we're helping you get pregnant, but it's also diagnostic. And so this may be part of the big picture of what has led you to ending up needing IVF to begin with.
Great. Well, great episode. And so to our audience, thanks for listening, and tune in next week for more. Also, be sure to subscribe and leave a review in iTunes. We'd love to hear from you. You can follow us on Instagram or Facebook, and please hop on and leave us a like or a comment.
You can also visit fertilitydocs uncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye. Theralogic's reproductive health supplements are formulated for both women and men. These products are designed by doctors and backed by science and are recommended by the majority of IVF health clinics in the U.S. Theralogic's fertility supplements are independently tested and certified by NSF International to ensure content purity, accuracy, and safety. If you're ready to start your family, Theralogic's has you covered every step of the way.